Please take your seats. The program will begin momentarily. Please welcome the Atlantic's Senior Vice President of Partnerships, Molly Cox.
Hi, everybody. Good afternoon. Thank you for being here. I am delighted to welcome you to the next frontier for accessible medicines. How can we improve access and affordability for safe, quality, and effective medicines and treatments? Today, we will convene leading experts to survey the biosimilars landscape, to unpack the growing gap in the biosimilar development pipeline, and to explore the regulatory, economic, and policy solutions needed to secure the future. Please silence your cell phones and your watches, but keep them handy and use the hashtag AtlanticHealth. Before we begin, I want to thank our underwriters, the Association for Accessible Medicines, and the Biosimilars Council for their support of the Atlantic's journalism. To share a few opening thoughts, please join me in welcoming the President and CEO of the Association for Accessible Medicines, John Murphy.
I had to look at my watch. I was about to say good morning, but good afternoon. We're thrilled to be here with the Atlantic today. As was said, my name's John Murphy. I'm the President and CEO of the Association for Accessible Medicines. AAM, for those of you who don't know us, is a trade association based here in Washington that focuses on helping to ensure America's patients have access to the prescription medicines they need at an affordable price that fits their budget. And we do this by working with the federal and state elected officials, the media, and other stakeholders to generate the most sustainable market conditions for the generic and biosimilars medicines industry here in the United States. I'd like to welcome all of our esteemed speakers, including Senator Ben Ray Luján of New Mexico, who you'll hear from shortly. I'd also like to introduce to you, although he's not on stage, he will be shortly, a new member of the AAM team, Keeton, who will be joining us as the new Executive Director of the Biosimilars Council and to run policy for AAM. Before we get started on the content, let me give you a little background on the state of the generics industry in the United States. Generic drugs are one of a kind, truly the backbone of the U.S. healthcare system, accounting for over 90% of prescriptions filled on a day-to-day basis in the United States. In 2024, generic and biosimilar medicines, while comprising 90% of all prescriptions, only accounted for 12% of prescription drug spending. In sharp contrast, brand drugs supported patients only 10% of the time, but added up to 88% of the total drug spend. Let's break that down a little bit. Americans spent $98 billion in 2024, filling 3.9 billion generic prescriptions. They spent $700 billion filling 435 million brand drug prescriptions. What does that mean? The real way to look to lower the cost of medicines is to have a robust generic and biosimilars market in the United States. It's more apparent when we zoom in on biosimilars, which will be more of the topic today. They've saved the U.S. healthcare system over $56 billion since the market entry just about 10 years ago here in the United States. Earlier this year, we did a study with the IQVIA Institute and identified what we're calling the biosimilars void. So despite their proven value, biosimilars are facing barriers at every turn in the United States market. If nothing changes, patients in the healthcare system will pay the price, especially because a staggering 90% of biologic drugs that lose exclusivity in the next decade have no biosimilar in the clinic or in development. This is the void we have talked about. A fully competitive biosimilar market, just with those products that we've currently identified, would save the U.S. $189 billion over the next decade. But we won't realize those savings if we don't amplify this market and put it on a more sustainable path. And that's what we're going to talk about more today. For now, thanks again for those of you who joined us, and I hope you gained deeper insights today about the state of this market and the complexities and value of our generic and biosimilars industry. Thanks very much.
And now, for a conversation produced by our underwriter, the Association for Accessible Medicines and the Biosimilars Council, please welcome Matt Erick, Chief Commercial Officer, Advanced Markets at Biocon Biologics, and Alex Keeton, Executive Director of the Biosimilars Council and Senior Vice President of Policy at the Association for Accessible Medicines.
Thanks so much. Thanks so much, everyone. Good afternoon. As you just heard, my name is Alex Keeton. I'm the Executive Director of the Biosimilars Council and SVP of Policy here at AAM. And I'm pleased to be joined today by Matt Erick, Chief Commercial Officer of Advanced Markets at Biocon Biologics. And we wanted to do a bit of a deeper dive into a topic I think John just mentioned, which is the biosimilar void, and getting a little bit into what that is and what that means for the health of the biosimilars marketplace and how sustainable it's going to be. So earlier this year, we released a report assessing this biosimilar void in the United States and had a lot of great findings in it. If you haven't had a chance to check it out yet, I would encourage you to take a look. But one of its main findings and kind of the purpose of the report is that it looked at all of the biologic products that are going to experience patent expiry in the next 10 years. And of those products, it found a huge potential for savings, for a role for biosimilars to play. But troublingly, as of when the report was released, it was September of last year when they kind of cut the data off, only 10% of those 118 products that are going to face patent expiry in the next decade currently have biosimilars in the pipeline. And so that lack of biosimilar development is what we call the biosimilar void. So Matt, I'm curious, obviously we looked at the report kind of from a data and analytics perspective in these products that are going to lose patent expiry, but your company is a biosimilars manufacturer. How do you think about that biosimilar void in practical terms, and what in the report really resonated to you as you think about the biosimilars market and where it's going?
Yeah, thanks, Alex. First, let me thank AAM and also the Atlantic for the invite. Appreciate to be here. Let me start with the pathway. Currently, biosimilars have to play in the pathway of brand and innovators. And if you look at this, I believe, and I think there's a whole lot more savings. The current brand innovative pathway is costing biosimilars billions in savings. Let me expand upon that, okay? So AAM he's referring to was a study they did was about $56 billion in savings to date that biosimilars for the US has contributed. That's significantly a lot of savings, and that has to do with access and affordability. But I would say it's been limited. It could be more. And the reason I say that is that we're going to hear more about interchangeability. We're the only country in the world that has interchangeability status or information that is needed. When we look at our European colleagues, they don't have that. And I also will say, in our current format, we're almost always last for biosimilars to come to the market. Why is that? When our European counterparts, our Canadian counterparts, and around the world are launching biosimilars, and it's proved to be a good thing. And what I mean by that is that we have to look at phase 3 studies. Why are we continuing to do phase 3 studies after almost 8 years of proven clinical information around biosimilars? Not trying to cut corners, but if we want to address the opportunity, that's one other way we can get more biosimilars to the market to have more access and more affordability for Americans. The other thing we need to look at is really the purchasing of reference product. These are where biosimilars need to buy branded products to do studies. Those are expensive. There's also reasons behind we need this and also reasons why innovators look at how we have access to reference product. The other thing we need to focus on and talk more about is ASP reform on the Part B side. And what I mean by that, if you really drill down, it's at the end, it's about the patients and it's about their caregiver. And if you know, we can talk more about ASP later, how is that really helping the patient when ASP is really about looking at products based on a monetary piece on really purchasing product, not giving care. So we should discuss that. The other thing we need to look at is from a standpoint of how some of our counterparts around the globe we have very self-reflecting on the United States. When you look at a global manufacturer, and there's other here in the audience, we look at where we're going to put our investments. Because biosimilars, when we come to market, are about anywhere between 100 million to 300 million. And I'm not trying to make excuses here. We know that, but we have to make this investment up front 8, 9, 10 years later. The other thing we need to look at is truly the patent thicket piece. What is really relevant? Not taking away of anything from the innovators or brands, they're very relevant. But where does it make most sense? And I know in the audience we can name some products that make sense and maybe some that, why did that really make sense? So I think, Alex, these are all things that the association, I think legislation we'll hear from the senator later today, that really are impactful to bringing these medicines that are high-quality medicines to the U.S. citizens to be able to have more affordability around care that maybe they're not getting today. It will expand access. We've seen this around the world. So thank you.
Yeah, absolutely. I want to go a little bit deeper on the point of access, because one of the things, in addition to the top line savings numbers that the Void report found, was that there's a pretty wide disparity in the number of therapeutic areas where there is no development, right? So for the 10% of products that are going to lose patent exclusivity in the next 10 years that have biosimilar pipeline, heavily concentrated in immunology and oncology, but there are lots of other therapeutic areas where there right now is not. Can you talk a little bit about not just patient access to lower cost medicines, in biosimilars, but also the provider experience in maybe not having as much experience like with biosimilars and maybe contributing to some of those education and misconceptions that you were talking about?
Yeah, I think the U.S. is getting more comfortable with biosimilars. We've seen this. I believe we need to adopt looking at it from a biosimilar first standpoint. And what I mean by that is, why, from a payer perspective, do we continue to have innovators on formularies? There's reasons behind it, but also there's reasons that we should consider, well, if the biosimilars are available, what's really are we looking at in the payer side? The payer has absolutely, an important role to play, but we need to ask ourselves, why are we looking at, we'll use Stelara as an example, and Humira. They're very opposite. Humira still has the innovator on formulary. And there's reasons behind, and you can get more curious to that. But when you look at Stelara, the payers have already started to move away in July from the innovator. They're both in Part D, and they're both immunology. And then you look at some of the innovators going into your Skyrizi or your Rinvoq, and you ask yourself, well, what's the best piece for the patient? What's the best outcome? If some product has worked for 20 years, why are we now moving everything at a higher cost to the new innovator? Is it something that's needed? Not take away from our great caregivers or patients. The question needs to be asked. And I'm not talking prior authorization, because that doesn't give what we're looking for here. It's really about how the payers and how we need to look at these on putting them on the formularies and being able to drive that access and compliance.
Absolutely. We've talked a lot about, some of the solutions that you see, ASP reform, rebate reform, thinking about the payer component. Is there anything else that comes to top of mind and specific for your guys' biosimilars pipeline at Biocon that you really see as impacting the biosimilars market and that would really make a difference?
Yeah, look, we can, it's like anything, we can take more shots on goal. If we can look at ways to decrease the amount it takes to get to the market. And when we look globally, there are different ways in which the European piece we can get to market versus as we're looking in the US. And I think if we can start to overcome that with the 112 or plus more and over $250 billion, $250 billion, we can do more outside of taking those opportunities and taking that risk from an R&D perspective and taking the risk of getting the approval from FDA or EMA, which Anvisa or wherever around the globe, to say we can bring these to market. Right now, what you're seeing is most of the biosimilars, we're all bunched up. We're all bunched up in the multi-billion-dollar one because that's where the pirates see all the treasure. But honestly, if we look at this from a caregiver perspective, it's really about looking at all these opportunities. When the patents are expiring and the opportunity to be able to bring the $2 billion or the $1 billion or the $500 million biosimilar to market. But as we know, there's only so much of an investment biosimilars like Biocon or other biosimilars can put into it, and we have to start looking at how can we take some of this reform, interchangeability, also the phase 3 trials. All this allows biosimilars to have more opportunity to take these risks in R&D to bring high quality biosimilars that are affordable and accessible to the market.
Great. Well, I think that brings us to the end of our short time. I think, we at the Biosimilars Council are going to keep leading the charge on some of those reforms and hopefully create a more sustainable and resilient biosimilars market. So everybody join me in thanking Matt for his time.
Yeah, thank you very much.
Thank you.
Here to discuss policy solutions to bridge the biosimilar gap, please welcome Senator Ben Ray Luján of New Mexico with Jean Meserve, contributor at Atlantic Live.
Wonderful to be here with you all and with you. So we've heard a lot already this morning about how biosimilars could lower healthcare costs and improve accessibility, but there are obstacles. Some of them are policy obstacles, and we're going to talk with the senator about how to knock some of those down. Before we get deep into the policy discussion, a personal question. You've spent a lot of time on drug costs since you have been serving in the Capitol. Why?
Well, Gene, this is a matter of life and death. If people can't afford life-saving tools out there, what good are they? The other area that I brought a lot of attention to is making sure clinical trials are diverse. That's a good word for me. If we don't include people from different backgrounds, different ethnicities, different races, in clinical trials, there's going to be winners and losers. It's not an affordability thing at that time. There are going to be people that die. And, being someone where, brown skin, hey, this affects me. So whether we're talking about clinical trials with life-saving medication or even wearables, with all that's going on with AI and all the rest, we need to make sure that we're being smart about all of the inputs that go into these models and that we help more people. I mean, that's really what drives me.
Also important to have men and women
Amen.
in the trials.
Yeah, it turns out it makes a difference.
Yes, it does. So what potential do you believe that biosimilars have to change the healthcare landscape in this country?
No, it's affordability. Why is it that someone's paying astronomical costs when the same medicine rides side by side and keeps money in your pocket? People across America having to make the toughest decisions on whether they're going to take their medication or not because they may or may not be able to afford it. That's what this just comes down to. With everyone in this room, with the work that you do in this space, with the kind of legislation I'm sure we're going to talk about here, whether it's looking at interchangeability and empowering people to make decisions on the fly so that way you can make that purchase or that acquisition, or looking at switching and policies that are in place right now that just make it harder for people to be able to access life-saving medication because of the affordability side. That's what it comes down to: keeping money in people's pockets, making it affordable, making sure that this life-saving medication is going to reach all of us, no matter where we live, what the zip code is, but that when it does, you can afford it. And people aren't even having to make decisions where if they can afford the medication, then they say, okay, well, I need to stretch it, so I'm only going to take half a dose. Well, it turns out that doesn't work so well either. We need to make sure that people are able to access life-saving treatments. And this really drives me. In a state like New Mexico, where traditional banking has not been the best to my constituents, families like mine, there's all kinds of challenges there just from an economic perspective. That's just the reality. And there's a lot of parts of America like it. When it comes to living a healthier life, it shouldn't just because you can't afford it or you can't. We have to do better in America. And this group and this forum represents one of the very best ways that we can make a positive step forward.
So regulations are in place to make sure that the pharmaceuticals we use are safe. Do you believe there is a way to streamline regulation in such a way that those drugs would still be safe to use?
Yeah. You know, we don't have to make the environment less safe to make it more affordable. We just have to make sure we get out of the way of innovation in the space of biosimilars, of generic drugs. I mean, I think that's how most people know them across the country. And look at some of these barriers that exist to allow it to happen. Because it seems to me that some of the policies that I've been working on, one with Mike Lee and with Maggie Hassan, it's a matter of word change. It's a matter of changing some policy that needs to happen at the congressional level, because under the previous administration, they did as much as they could, it seems to me, through the rules and the laws that exist. Now it takes law changes. I mean, we have to make these language changes to allow this to happen.
But you're convinced they'd still be safe, these drugs? even-
Absolutely, they'll be safe, yes. I mean, you know, would I take my mom to buy them? Yes. That's the measure of being safe. If it wasn't safe for my mom, she wouldn't be going to get them, not with me in the room.
So one issue you have focused on is interchangeability. It came up in an earlier discussion as well. First, explain what interchangeability is in this context of biosimilars.
Yeah, just because a prescription drug has a brand name on it should not restrict you from buying the exact same medication for a lot less expensive. Interchangeability, being able to swap it. I mean, call it what you want. The word that we are having to use, I guess, for legislative purposes, the way that it's been drafted is interchangeability. But that's all it means. I go in to get my prescription drug. Turns out that there's another drug that does the same thing, same drug, same research. Research is done to show the benefit, but because of the law, I can't buy that one. Or someone's making it harder for me to buy that one. Why? That's my choice as a consumer, especially once the FDA and everyone has had their say, they've looked at this, the efficacy of this. Yeah, I should be able to get it. It's that simple. Looking at the law to allow this to happen.
So the FDA did announce some changes to their policies on interchangeables. Did they do enough? What's your assessment?
From what I've been told and my research in looking into this, they went as far as they could based on the current law. That's why these laws, that's why these pieces of legislation are needed, to be able to change the law, modify the law, I would say update the law, to allow the FDA to do its work and allow consumers to have more choices, not less safe choices, more healthy choices that are going to keep money in their pockets, make it more affordable. When healthcare is more affordable to people, more people access it.
Can you be specific about what additional changes on interchangeability you're proposing or you'd like to see proposed?
It's allowing it. It's allowing, in the case of being at the pharmacy counter, so for a doctor for prescribing, but also at the counter, if you're there purchasing, to be able to make that decision on the fly when the physician has said that there's something that's more accessible, or as you all know, when you're at the pharmacy and you're getting something and the pharmacist says, hey, did you know that generic option A is 1,000% cheaper, and was that number too low? Is less expensive. Do you want to buy this one because it's the same medication? And so it's allowing that change to take place as well as with the prescriber as well, which oddly enough right now barriers exist. And again, who was in the room when these rules were made or these changes were put in place? That's always my question when I ask, why was this impediment created to begin with? It seems to me that if you go to medical school, you're researching this, the FDA is doing their job, and you show that it's safe, why can't I as a consumer in the United States of America be able to purchase that?
Correct me if I'm wrong, because I'm not an expert in the field, but my understanding is that the biosimilars aren't even available for the consumer or for the pharmacist to prescribe because of requirements around interchangeability. And
Yes.
the kinds of testing that has to be done in order to get that classification.
Yes, again, another barrier that was put in the way of FDA being able to work with innovators across the country that are working in this particular space. Right now, the FDA has to say no. It doesn't exist. And so that's another barrier as well, is just being able to get to that place. But again, the simplicity of the interchangeability legislation is saying this can happen. If the FDA says this is safe, we can move forward. But right now, the FDA is not even put in a position to allow that to occur. And then it trickles down to the physician, to the prescriber, to the pharmacist, looking at those options as well.
Let's talk for a minute about pharmacy benefit managers. What exactly are they, first of all? What do they do?
Look, it's, a friend that you all may have that says, hey, I'm going to help you sell your drugs, and you give me a price, and then I'm going to negotiate with you and get a lower price, and then I'm going to go enter into a bunch of contracts, and then I get to keep what's negotiated. It's also my beef with pharmaceutical companies as well, branded pharmaceutical companies. List price versus the negotiated price versus the lowest price. One piece of the interchangeability component here is just, it's about transparency. Let's know what the price is, not the list price that I can negotiate and find the middle space. It's the middle person that's getting in between the patient, the pharmaceutical company, and it costs more money. Again, my beef in this particular area is let's get a price. What's the price? Branded pharmaceutical companies know what they're willing to negotiate to. That's the list price. Let's just start there. Let's get to the place. Let's get everyone the best price. Let's make sure people can afford medication more.
So are you suggesting we should get rid of the pharmacy benefit managers then?
In the current form that it exists today, I don't know what the added value is here with being able to get that to market, with being able to get someone the best price. When I visit with PBMs or I visit with branded pharmaceuticals, no one will tell me the price because they say it's contractual. Well, what's that garbage? Contracts work when one party chooses not to tell you what the other party doesn't want to tell you. You all are choosing to keep this a secret. That's what's going on here, because there's a benefit to you. Well, there's a profitability aspect to this where you can still line your pockets with more money, as opposed to saying, hey, we know we're willing to take this price. Let's get it to people. And I guess that's where I get frustrated with all of this.
In 2022, you introduced legislation pertaining to animal studies in the approval of biosimilars. What role do those play, first of all?
I mean, look, Rand Paul has been a great partner in this space, and this is just one of those examples. I'm willing to work with anyone when I think it makes a positive difference in people's lives, just looking at ways that we can improve the environment as well, where it's needed, where it's not. And some of the abuses that we've seen in the past, I think it's that simple with why Rand Paul and I came together to work on that particular piece of legislation as well.
So can you explain to me what role the animal studies play in the approval of biosimilars?
Well, look, the approach that I've taken into a lot of this is, where have there been abuses in the past where it's been needed and where it's not been needed as well, just looking at people and including people or lack of clinical trials as well. And how can we make changes in the law so that way we're safeguarding a little bit more as well? To me, the simplicity in that space is how I would describe it.
And I just want to go back to this again. Are you sure that without these the interchangeability test, the animal testing, are you sure that these drugs would still be safe and still be effective?
We're not telling the FDA to sell people drugs that are going to kill them. I mean, it
But
has
could
to
they
be
be
safe.
sure their green stamp?
Nothing in this legislation will make them less sure than they are today. All that we're saying is that there needs to be an alternative when it's proven that the science allows for this to be safe and sold to people, that it shouldn't just be some branded, some proprietary nonsense associated with not being able to allow biosimilars, generic drugs, to be able to be sold to people. Plain and simple. It's not going to make it less safe.
The FDA is central to this whole process, obviously. There have been serious cuts at the FDA. Now there are furloughs. Has all of that had an effect, do you think, on biosimilar approvals, or will it?
Sure, less people doing the work that they should be, looking at approvals that should be considered, creates a backlog. Now, we're not in normal times. The way that this administration is pursuing things, I disagree. Arbitrarily getting rid of people for the sake of doing it politically, as opposed to, a thoughtful way to be able to create efficiencies in the federal government. That's not what's occurring today. When the administration fires, people that are responsible for safeguarding national security responsibilities with nuclear weapons at the National Nuclear Safety Administration, you fire them on a Friday, you try to hire them back on a Sunday, you don't have half their phone numbers, there's a problem. The United States Department of Agriculture fired a bunch of epidemiologists, as you all know, who have responsibility to safeguard America if there's threats. Well, right now there's a port in New Mexico that's closed because of one of those problems that should have been solved, at least made us a little safer, a little more prepared on behalf of the United States Department of Agriculture. And by the way, all this PBM reform, at least the White and Crapo bill, would have been done had it not been for one person, and I'm not saying the president here, Elon Musk. December of, 24? There was an agreement passed the Senate. It was sitting in the House. The House was supposed to go to a vote, not just for funding. So we wouldn't have had a CR that year as well, continuing resolution. We would have had this reform package would have been adopted. Elon Musk decided to go to social media, and a bunch of Republicans just went along with him. And those that said they were going to vote for this package changed their votes, went down for it, and they killed it. I mean, that's also the nonsense of the political aspect of why this exists and why this is still needed, as opposed to why was this not signed into law by the President of the United States already.
Do you want to issue a call right now for the president to rehire people at the FDA in order to move this process along?
Yeah, if it helps, sure. The president listens to all my advice.
I'm sure he does.
But, I hope, look, in this very narrow space with affordability of prescription drugs, President Trump said that he was going to fight to make prescription drugs more affordable. There's a responsibility from HHS where they're supposed to be negotiating, 700 drugs now, Kelly? Or so, I don't know what the list is right now, but whatever the number is. And some of you may know of conversations taking place. I don't. There's no reporting. There's no sharing of information. As a matter of fact, a lot of many of the secretaries now serving all of us have been telling their employees to stop talking to members of Congress, Democrats in Congress. But that's some of the nonsense happening. So I hope those negotiations are taking place. Now, with all that being said, if President Trump wants to do something about affordability, he can be a hero right now. He can ensure that the FDA has the staff, the professionals there to do the work. He can ensure that the Secretary of Health and Human Services is truly negotiating. And he can do something by leaning into Congress and saying, hey, pass the PBM reform legislation, which he said he supports. It's bipartisan. It's ready to go. He should give that nod and tell Speaker Johnson and others, bring everybody back. Let's get to work. Let's get this stuff done.
The president's recent executive order on pharmaceuticals directs the FDA to streamline the approvals of biosimilars. Is that at least encouraging to you?
Let's see what they do. I mean, it sounds nice. And by the way, maybe in doing that, the president should issue another executive order that says, hey, all the tariffs that I'm slapping on making prescription drug prices more expensive today, because it turns out you can build a bunch of manufacturing facilities, but if the inputs are getting more expensive, it turns out that it's going to be more expensive. So there's a few things that we can do. I certainly hope that people will listen to the president and do it in a thoughtful way, in a safe way, that if we can find efficiencies, if we can root out waste and fraud, I'm all about it. And do it in a way that's safe for the American people, but will ensure that these biosimilars are able to get to market and that people have choices. We should do all of these things.
What has the impact of the Inflation Reduction Act been on biosimilars?
look, I mean, you all tell me. When we look at research that was done associated with looking at the law to be able to get more biosimilars available to the American people, looking at some of these barriers, that's a good thing. Then the question is, from one administration to the next, you all know better than I who's doing the work, who's not. Are there artificial barriers that are being created that are not being reported? Is there language that still exists within rulemaking or another that is still in the way and is still an impediment? And I'm not suggesting one party or another. It's one personality over another personality, a different person in the room, ramping up staff that may not be as familiar. Is that learning curve where it should be, or the implementation where it should be? But I always think that there are, even though I believe legislation has contributed in a positive way, the question for me is always on the rulemaking, the implementation, and carrying out to truly create a more positive environment for the American people. And I just don't know where things stand in that particular space today. And I mean, I'd be real interested in getting feedback in there.
Without the changes in policy that you've suggested, what do you think the fate of biosimilars will be? Is it possible that they will disappear from the landscape?
Anytime a very wealthy conglomerate feels a threat from a dollar being taken from them and moved elsewhere, they move to squash something. I believe that that's what will continue to happen, because if one industry wants to, or a sector of an industry wants to stamp out a competitor, that's what happens in the United States. That's why legislation is sometimes needed to say, hey, you all tell me that we need to get these life-saving drugs and research to people to save their lives. Why are you making it harder for people to get them? And that's why legislation is needed. So I'm very worried without language to eliminate barriers. It makes it easier for those that don't want to see biosimilars available to consumers, easier for them to stamp it out.
We've talked about a number of different possible things that Congress could do. What do you think is the most important? What's the top priority when it comes to biosimilars?
Well, let's get them to people. And look, there's a complexity to all of the policies, I'm certain, that exist that will allow for that to happen. So that's a long list. But if the goal is we need to ensure that as a patient, I will benefit from being able to purchase that biosimilar, make it more affordable for me to take it, well, let's look at it through that lens, and then let's look at the list of legislation, because I don't know that it's just one. I don't know that it's just one rulemaking, one policy change. There should be a project that allows us to get to this place, and then let's move everything at the speed that it deserves to be able to ensure that this is truly accessible.
Given the deep partisan divides in Washington, do you think it can get done?
No, look, the major PBM reform legislation is Mike Crapo, Ron Wyden, conservative guy, progressive guy working together. The legislation that I'm working on is Mike Lee, Maggie Hassan, Ben Luján. You probably wouldn't partner the three of us together on a lot of pieces of legislation, and oftentimes we're the ones sparring with each other in committee and on the floor. We're working together. With what I did with Rand Paul. You know, Rand and I disagree on a bunch of things from a policy perspective. He's a good guy. I don't mind sitting down and chatting with Rand and, you know, talking about Kentucky or talking about bourbon. But there's ways for members to work with one another. And I think one of the lost arts, one of the lost responsibilities that we have as elected members to the U.S. House, to the U.S. Senate, is talking to each other. You know, everyone likes to talk about Tip O'Neill and Ronald Reagan. That was a president, Speaker of the House, for those of you that are very young. Look, they sparred in public all the time, but they'd get together and they'd sip on something brown, and then they'd chat a little bit and have a meal.
It wasn't a biosimilar, I might add.
And they probably needed a biosimilar, but they work together. It's getting harder and harder to talk to people, and you know there's these barriers that people put up artificially. look, I may contribute to the problem, I'm certain on occasion, but I'm one of those annoying senators that if I can't get a meeting with you, I'll go sit in your lobby with the front office staff, and you're going to tell the chief of staff, the scheduler, the member, whoever it is, hey, Ben's in the lobby and he's not leaving. Can you just talk to him a little bit? I mean, I'll go walk someone's dog. I'll go throw someone's garbage. Whatever it takes. When Pete Buttigieg was the Secretary of Transportation around the corner, I found out where he walked. And sometimes I'd be on that same walking trail, and I'd get 5 minutes with the guy, right? We have to find ways to talk and get things done. So, yes, things are bad. There's distrust with staff. There's distrust with a lot of people that should be talking to each other. Some of your former colleagues, people that you all know very well. We need to talk to each other and make that happen again. And by the way, when we do, let's also keep our word when we have an agreement with each other to work on something. One of my greatest fears is, as you all know, you may go into a room, have a meeting with someone, come up with some solution. But before the door closes when you leave, the deal's dead. People need to keep their word. And that trust needs to be reestablished with all of us here as well. So I'm hopeful, and I even with all the division that exists, I still believe that people are here to do good. And we just have to find whatever that agreement is. And it's going to be different with different people, but on any given day, you just never know the 2 or 3 that it's going to happen with.
And we will leave it on that optimistic note.
Yeah.
Senator, thank you so
Gene,
much.
thank
for
you.
joining
Y'all,
us.
thank you for everything you do. Thank you so much. I have a vote I have to get back to, so I have to excuse myself quickly as well, but please come by the office. Callie with our team is here somewhere, who many of you know. Thank you for continuing to reach out to our office and helping to educate me as well. And for those of you that are not headquartered in New Mexico, what's your problem? Get over there and get headquartered. So we'll get you there soon. Thanks again, everybody.
And now for a conversation on building a sustainable pipeline for biosimilar development, please welcome Kelly Anderson, Assistant Professor in the Program on Regulation, Therapeutics, and Law at Brigham and Women's Hospital and Harvard Medical School, Kimberly Maxfield, Head of U.S. Regulatory Affairs at Biocon Biologics, with Jean Meserve, contributor at Atlantic Live.
Well, that was quick. Back again. Great to be with you again. As was mentioned earlier, 90% of the biologics are expected to lose exclusivity within the next 2 years. 90% of them do not have a biosimilar in development. The question is why, and what can be done to build a better pipeline to bring them to market. Kelly and Kimberly are here to discuss exactly that. Kimberly, we talked about this biosimilar void a little bit in earlier sessions. Do you think the statistics are correct?
So first off, just thank you for the invitation to be here. And just to give the audience some context, I currently work for Biocon Biologics. I was actually at FDA until the end of May. So I've been at Biocon for about 4 months, and I was at FDA for almost a decade prior to that. So I'm speaking both with my regulatory hat on and a little bit of my industry hat on as well here. So yeah, a lot of people the new jargon term is biosimilar void. And that IQVIA report everyone's referring to, the FDA had a public meeting on September 18th on 2025 about the biosimilar regulatory science pilot program, and at that's public, you can Google that, where it said that they have received 129 meeting packages for 63 reference products. So at least from what has been submitted to FDA, the number is higher than what the IQVIA report is reporting.
But still not great.
But, right. But I think ultimately from a policy perspective, I don't know that the numbers matter as much as there's obviously a lot of opportunity to there are a lot of barriers that we've heard today, and there's a lot of opportunity to try to move biosimilars forward to increase accessibility.
So we're going to dig into some of the specifics in a moment, but first I'd like to get sort of an overview from each of you about what you see as the biggest obstacle to biosimilar development and adoption. Why don't we start with you, Kelly?
Sure. So I think one of the biggest challenges I see, and I think about biosimilar adoption, so once we have biosimilars available, what is their uptake and what does their pricing look like? And I think one of the big challenges that we see is it's, even if a drug manufacturer wants to develop a biosimilar, it's hard for them to actually get market share if they bring it to market. And so there's not a lot of incentive on the front end to even think about that biosimilar development. And so we see, for example, in some of my research that when drug manufacturer has a biologic product and they're selling to hospitals or clinics through injection and infusion Part B drug products, that they leverage the other set of drugs they sell to those same hospitals and clinics to maintain market share with their reference biologic, rather than allowing adoption of a potentially more affordable biosimilar product. I think when we think about the biologic and biosimilar market, we don't see the same kinds of more rapid uptake of our biosimilars as we would see generics, or the kinds of price falls we might expect otherwise, because of some of that market power. And that really very much does not induce drug manufacturers to think about entering the biosimilar market as a result.
Kimberly, from your perspective?
Yeah, so from a kind of pre-market development perspective, the amount of time and the money it takes to develop a biosimilar in comparison to a generic product is orders of magnitude larger.
Why?
Primarily, not in total, but primarily because historically a comparative efficacy study, or many people refer to this as a phase 3, but it's like a comparative efficacy study is required to compare the efficacy and safety between the reference product and the biosimilar. Clinical data is very, very expensive and takes a very long time to generate.
I understand there is discussion about removing phase 3 trials to encourage development. Are you seeing that as a positive development then? Is that a good thing, that discussion at least has been broached?
Yeah, it's so at the advent of the biosimilar pathway within the U.S., there were a lot of theoretical scientific safety concerns that were sort of embedded in the pathway and embedded into how FDA interpreted the pathway and the scientific data that was required to meet the standards. We are now 10, 15 years in the future. We have a lot of experience. We have billions of years of patient data across the globe experience. And at this point, there's been a lot of discussion across the globe, and it's starting to come out to the U.S. that a comparative efficacy study is actually the least sensitive measure to try to detect a difference.
Let's talk about interchangeability, which you heard the senator say was a major obstacle here. Kimberly, why don't you go first and talk about it a little bit, what this involves and how it could be changed?
Yeah, and the senator did a nice job distinguishing between, the law has, in the statute, there is a designation, a legal designation for interchangeability, and the scientific data that FDA can sort of leverage to then meet that standard. And he's correct in the sense that the FDA has gone as far as they can to lower that barrier while that part of the law still exists. So historically, initially, FDA put out guidance saying a switching study, a clinical switching study, which is what you would switch patients back and forth, was going to be an expectation. Again, with a lot of experience, FDA has learned that this sort of the theoretical scientific concern with switching did not come to fruition. It's not really a concern. And so they have changed their interpretation of the statute via a guidance in June 2024, saying that a switching study isn't necessarily required to meet the standard.
And they're expensive to do, right? Because the people doing this,
expensive.
because they have to buy the reference
Well,
biologic, right?
You have to switch. So the initial design of those studies where you were switching 3 times between, For most biologics, the dosing regimen is every 3 weeks, every 4 weeks, some are every 6 months. So if you're ever trying to switch, I mean, those are very long studies. You have to deal with dropout. It's very complex.
From an uptake point of view, what does the interchangeability designation mean?
So I think to some extent it's a clinician confidence question, right? Especially for injection and infusion products, which is what a lot of our biologics are. It's a question of what drug does a clinic or a hospital want to purchase, and what product does a clinician or the hospital system feel confident in administering to their patients, right? And so, especially if someone's not in the weeds of interchangeability or in the weeds of biologics, what level of confidence do they have, and how do they feel confident in the same way that a generic is the same product as a reference small molecule? Do we feel the same way that a biosimilar is the same as a biologic? And so I think whatever terminology we're throwing around there, so much of this comes down to what is the clinician's confidence when they're prescribing it.
And what about the patient's confidence?
Also that, right? In the way that I think most of us as a patient probably wouldn't think about, exactly what name of a drug if we're going to pick it up at a CVS. But if you've been on a product that works for you for a long time and your insurer or your clinician tells you that you're switching to a different product, you might understandably have reasonable concerns, even if these products actually are biologically doing the same thing. And so I think it's definitely one of those of it's a building understanding kind of question.
How do biologics perform, Kelly, when they are introduced in the market right now?
What do you mean by perform? Do you mean from an uptake perspective?
Yes.
Yeah, so when a biologic enters the market, if it's a new mechanism of action or treating a disease we haven't been able to treat before, obviously there's massive interest in potentially prescribing that medication. When we see a biosimilar enter, we're treating something that we've already been treating previously, and ideally it is functioning exactly the same way as this product we already have on the market. I think one of the biggest challenges we see is that when a generic enters the market, we start to see more rapid uptake. Biosimilars, it's harder for them to successfully enter the market because of some of the ways that we pay for these products and the ways that rebates work and the ways that these are being purchased in large part in wholesale by a given hospital system or purchasing group or clinician practice. And so it's challenging for a biosimilar to think about market entry just because it's harder to gain market share when they're trying to do so.
Are there changes that could or should be made to Medicare or Medicaid that would change that?
So I certainly think one of the options is when we think about clinician-administered products and we think about small molecule drugs, we calculate an average sales price that pools the prices together of the small molecule that's the branded product and the generic prices. And so a clinician or a hospital system can purchase whatever product they want to, but there's an incentive to purchase the lowest cost product available because you're getting reimbursed an average of the prices across those products, right? But when we think about biologics, at least for Medicare, we don't calculate the reimbursement for the biosimilars tied to the reimbursement for the biologic. And so there's less of a market incentive and competition to encourage that biosimilar uptake.
Kimberly, how does the regulatory approach towards biosimilars differ in the United States from what you see overseas?
Well, going back to your earlier question about the comparative efficacy study, there was I think in 2023, there was a international pharmaceutical regulators program meeting that was public that I think 40 regulators from across the world called into, and the title was increasing the efficiency of biosimilar development, and it was almost exclusively, the discussion was almost exclusively about, needing or not needing a comparative efficacy study, and what comfort, sort of from a global perspective, do regulators need to understand that that's not scientifically necessary to demonstrate biosimilarity. So all of the regulators were there. EMA has since come out with a reflection paper. EMA is the Europe's FDA, is a reflection paper stating as such. MHRA, which is the UK's FDA, put out a guidance. Health Canada, which is Health Canada's FDA, just put out a draft guidance, all stating that a comparative efficacy study may not be required.
May not or is not?
So you're getting, in that question, you're getting into sort of the legal
Well, I'm just wondering how firm the line is.
So for most products, monoclonal antibodies, which are primarily most biologic products, the FDA still has to meet the statute, right? So they still have to say, we say there's no clinically meaningful difference. So the sponsor or the applicant is invited to provide a justification for why it's not necessary. The FDA is just saying, we think you could provide a justification that why it's not necessary.
So what you're telling me is that the FDA is out of step with what's happening, at least in Europe.
So recently, I think Healthline purported that the White House is looking at the current U.S. guidance. So I think it is presumably about that topic. So I think from a public guidance perspective, yes, they're out of step, but hopefully that won't be the case for very long.
So these things are used internationally. Is there any pooling of data? Are we sharing information amongst nations on what we've learned about these products?
Yes. So there's a couple different ways to go with that question. So as far as like cross-pollinating across regulators, there are called cluster meetings, which EMA, FDA, and PMDA, which is the Japanese version of FDA, I think quarterly will come together on calls and discuss how are you handling this. So like from that perspective, there is sort of cross-pollination. So if that's what your question is.
And I guess I would just kind of add on to that, from a more academic side of things, there's very much cross-pollination, right? Of like, these drugs are being studied in different countries and different patient populations, and the studies are being published in peer-reviewed journals that people can look at regardless of what country that data is coming from, and we're not seeing differences in the efficacy, right? And so it's even if each country has its own regulatory process, this evidence base is still being built cross-nationally.
Kelly, California recently experimented with state-led manufacturing of biosimilars. Tell us about that.
Yeah, so I think we're all kind of learning live time, right? So California, a couple years ago, passed state legislation that authorized the CalRx program, where California was seeking to develop a program to purchase and sell biosimilar versions of high-cost, high-need drugs within their state. Insulin is one of the first products they're rolling this out with. They've partnered with a nonprofit drug manufacturer to do so. I think, in the press releases we saw in the last week or so, they're announcing $11 per month for a 30-day supply of insulin.
As compared to what?
So always a good question when you're asking drug pricing, right? It's as compared to what depends a lot on who is your insurer, how is their formulary set up, which exact product are you taking? Are you taking the biologic or the biosimilar? But suddenly having $11 insulin on the market it changes the competition landscape a lot, I think. This is, a new pilot program. We don't have evidence yet on how it's working or what it's going to mean for patient adherence. But I think it's certainly promising that this is a new way to think about how do we make biosimilar medications more accessible and more affordable to more Americans.
Have there been any downsides discovered as yet?
So since it's right now just in the pilot phase, I would say no. There's almost always an unintended consequence of any policy we look at, but when we think about this, or at least when I think about this conceptually, it's a way to either patients get $11 insulin, which is more affordable, or it makes the branded drug manufacturers have to compete more on price. Both of those are good outcomes.
Do you think this is a model that could be implemented elsewhere?
I think so, and you could certainly think about products beyond insulin where this could also be promising. Certainly, we've seen innovative payment models for things like hepatitis C drugs with Louisiana, for example, over the years with what they call the Netflix model of purchasing them in bulk, right? And so I think any kinds of these different kinds of models really kind of give us hope and interesting different ways to think about how do we make drugs.
Are there others that you've looked at that look promising?
Yeah, so we can look at like insulin out-of-pocket caps, for example, at a state level and then rolled out through Medicare. And you could think about that not just applying to insulin products, but other kinds of products as well. And so I think there's, anytime we can see a state that's trying to tackle the problem from a different perspective and willing to test it and pilot it and evaluate the data, I think it's a really exciting thing.
How many states are willing to do that?
it depends on the model, right? So it's like we've seen 20-plus states roll out insulin out-of-pocket caps after Colorado. We're only seeing California so far doing this idea of cost-plus, state-sponsored manufacturing. California obviously has, more market power than a lot of states, but you could also think about other states pooling together to do similar kinds of collective agreements.
As a veteran of the FDA, Kimberly, as I discussed with the senator, a lot of staff reductions. Is this or will this have an effect on the biosimilar pipeline?
The current shutdown? Or just?
No, the furlough, the firings that happened under DOGE, the reduction in force, and then, of course, the furloughs are an add-on.
So.
Very deep sigh there.
The part of FDA that we're talking about here, the reviewers who review biosimilar programs are funded off of a user fee act, and that that funding is actually not appropriated, and so it in theory is independent. And so, for example, all user fee staff at FDA, last I heard, are still going in and doing their job. So anyone who had something already under review, those goal dates should be honored. Will it have an effect on? Yes, I can tell you that there are less people to do just the same amount of work. I was there, for those first few months after the RIF, and we had to be very creative. However, everyone there cares deeply about their job, and is what's coming out of the FDA less safe now? No.
I will just say that I just applied for a passport renewal, which is also user fee supported. Got my passport in days. So some things in the federal government are still working on that user fee model. Dream a vision here. What's the single regulatory or policy change that you think would have the biggest impact on the development and deployment of biosimilars? Kelly, you want to go first?
Sure. So we're going to get really wonky for a minute.
Uh-oh.
But I would change how we pay in Medicare for biologics and biosimilars. And this kind of hints back to what I was saying earlier, but we right now pay average sales price plus a 6% add-on payment for these products, right? And what that means is currently clinicians are incentivized to prescribe a higher cost biologic than a lower cost biosimilar. And the 6% add-on payment is intended for things like varying purchase prices. If you're a hospital, you can negotiate a lower purchase price than a smaller clinic can, right? These things fluctuate over time, that there's challenges and costs associated with storing these medications, like temperature control, not having a lot of them around light, certain things like that, right? But when we're thinking about what is essentially the same product, and we're saying, we'll pay you more additional money if you prescribe the higher cost version of this product versus the lower cost version, it's a real challenge to getting the biosimilar to be the first thing a clinician thinks of or a hospital thinks of when they think about these medications.
And what would it take to change that?
Federal authorizing legislation, right? So we need to move away from the ASP plus 6% payment system within Medicare. And then I think if you move away from that in Medicare, you'll see a lot of other payers kind of follow suit in how they think about paying for these products.
Have you seen any movement in that direction?
I've certainly heard interest in it. I'm not on the Hill day to day, so perhaps there's someone who's actively working on it, but I have not seen it kind of, at the top of mind of what's going on in federal legislation right now, but would love to see a representative or senator's office want to take that on and really lead the charge on it.
So, Kimberly, your number one priority?
So I think I would go back to not requiring a clinical efficacy study. So the underlying point of the biosimilar pathway is comparative analytics. And, biosimilars, those pathways, it's not to reestablish safety and efficacy. It's completely comparative, and we now have a decade of research or of experience showing that clinical data is not sensitive and ineffective at detecting differences if they should exist. And so I think those are so expensive and they're so long that developers are not investing in other things because they want to make sure they have the sufficient resources and funds to conduct those studies. And even with some, as developers get back feedback, like one-on-one for their individual development programs, often a statement as from a regulator saying, oh, we agree that you could provide justification and not require one, that's not enough assurance.
So given all the problems that you two have put on the table, bottom line, are you optimistic or pessimistic about the future of biosimilars? Kimberly, you want to take that first?
Optimistic.
Can you tell me why?
It's the future. I mean, it's
It's the present, actually.
yeah, but it's where, I have a life goal of working on a biosimilar program for a rare pediatric indication, and we will get there slowly but surely.
Yeah, I would say optimistic as well. I think, we certainly have seen biosimilar adoption in the U.S. lag other comparator countries, but what we're seeing in the last couple of years is much more promising than what we saw 3 or 4 years ago. Even if it's not yet meeting what we're seeing in the small molecule market, we're definitely seeing more confidence in biosimilars, increased uptake, some declines in pricing, though I'd like to see more. I think there's definitely both policy and regulatory levers we both thought about and talked about that could help that even further, but optimistic.
Well, that's great. Another session ending on an upward note. Thank you, Kelly Anderson and Kimberly Maxfield.
Thank you.
Really appreciate you being here.
Thank you to all of our speakers for lending their voices to such an important conversation. Thank you again to our underwriters, the Association for Accessible Medicines, and the Biosimilars Council. We are grateful to all of you for being here. Have a great day.